call upon Dr. Bennet. He is working currently as a medical officer in Aravind Eye Hospital, Coimbatore. Over to you, Bennet.
Thank you, Dr. Nadana. So we've been going through serious topics involving conjunctiva, cornea. So my topic is basically lids, lashes, and masquerades. So this is a image that I would want you all to remember, because many a times as ophthalmologists, we miss the findings that are usually hiding in the plain sight. So always look out for the most common things that can happen and that always presents before us in the slit lamp. So first I will be covering the conditions that occurs in the lids. This is just a recollection, I don't want to elaborate much. First one is blepharitis. So it's a chronic inflammation of the eyelid margins. We can differentiate it anatomically into anterior and posterior blepharitis. Depending on the underlying cause, we can differentiate into staphylococcal, seborrheic, meibomian gland dysfunction, and angular blepharitis. So elaborating on the signs in seborrheic blepharitis, as you can see collarettes along the lid margins. You can see more erythema and edema in the lid margin in cases of staphylococcal blepharitis. And MGD, which I'll be elaborating later, has got a lot of meibomian gland cupping that you can see. Management, as you all know, it's the regular management, that is warm compresses, eyelid massages, and eyelid scrubs. In few cases of staphylococcal, you can add topical antibiotics, or even sometimes a short course of oral antibiotics like azithromycin. Topical steroids and topical lubricants are kept for cases where the conjunctiva and cornea gets involved, and in case of MGD, thermal pulsation devices are currently available. Next, going into hardiola and chalazion. I'm not elaborating. Hardiola, easiest way to remember from the PG days, we've been reminded. Hordeolum is an infectious condition. It's a pus-filled lump. Chalazion is a sterile lipogranuloma. So the management should also replicate the same. Hardiola externum is in the outer edge of the eyelid, involving glands of C's or mole. Internum is inside of the eyelid, involving the meibomian glands. So warm compresses is the mainstay of management. In severe cases, you may have to go for incision and drainage. This is just a pictorial representation of same. You can see the external hordeolum, internal, and the chalazion. The next one is trichiasis and dystichiasis. Trichiasis are misdirected lashes growing inward, rubbing the ocular surface. This is usually an acquired condition, and it is usually following cases like trachoma, trauma, or other eyelid scarring. Dystichiasis usually presents with an extra row of eyelashes. Usually, few of them are congenital. Some of them are acquired due to the metaplasia of meibomian glands from chronic inflammation or chemical injuries. The treatment is epilation, electrolysis, and cryotherapy. In few cases where this condition occurs due to entropion and ectropion, you will have to go for lid correction surgeries. Coming to meibomian gland dysfunction, it's a chronic eye condition where the oil glands in the eyelids are clogged, not functioning properly, leading to dry, irritated eyes. Symptoms, as we all know, are burning sensation, redness, flakes and crust on the eyelashes, foreign body sensation, and dryness. Causes are also very well known. Management, again, just like blepharitis, involves warm compresses, lid scrubs, artificial tears. Omega-3 fatty acids were earlier recommended, but later in the DREAM conference, they told it's not causing any significant resolution. Intense pulse light therapy is currently a treatment of choice because it's a day care procedure, and the patient can get it done within 15 minutes. Surgical expression is an older method where manually the glands were expressed in high-grade MGD. So grading of MGD, just want to focus on three things whenever you are seeing an MGD case. See for the expressibility, see for the symptoms of the patient, and see the corneal involvement. You don't have to by heart or kind of stage it accordingly, but whenever the secretion, the quality of the secretion is getting bad, that's when you need to think that you have to treat it aggressively. Sometimes even when you press, but the quality of the secretion might be still clear and liquid-like. You don't have to go very aggressive with those patients. For plus diseases where coexisting or accompanying ocular diseases are there, you need to treat them first. Going into pre-cellulitis and cellulitis. So the major thing that you need to remember is these. Patient coming with fever, pain in the eye, proptosis and ophthalmoplegia. These are the sticking out signs. These will be present in orbital cellulitis, which is not just an ophthalmology emergency. It is something that where the patient needs to be admitted and treated aggressively. It can even go into a life-threatening situation. So it's important that you realize what preseptal cellulitis is, that is occurring anterior to the orbital septum, and orbital cellulitis occurring posterior to the orbital septum. Dry eye syndrome is a vast topic. I cannot cover it within this time, but I need you guys to take home something from this. So this is the T-FOS2 definition. It's a very large definition. We can break it down into 3. So it's a multifactorial disease characterized by unstable tear and ocular symptoms. So the etiological roles are played by tear film instability, hyperosmolarity, ocular surface inflammation, damage and neurosensory abnormalities. So many a times when dry eye patients come, we always think whatever be or what goes into your mind, at the end of the day, you're going to give lubricants. You may add some immunomodulators, and you will also treat the lids and lashes. So that's what usually happens in a dry eye disease. But before assessing the patient, you have to ask these questions to the patient. To the patient. That is there a tear insufficiency? You have to look for periocular aggravators, and you have to check the severity. And is there an associated systemic disease? And also, it's very important how the patient perceives the problem. Sometimes the patient may perceive it as a very severe problem, but clinically, you may find it to be a very mild or moderate dry eye. And before the patient, if you take up a very mild stance, patient may think that you're not serious about this problem. So it's important you need to listen to the patient. So these are the step 1, 2, and 3 and 4 of dry eye management. First, mainly involves patient education and lifestyle modification. Second step involves treatment of demodex and other ocular surface disorders. Step 3 is necessary where the patient's cornea and conjunctiva starts to get affected. And step 4 where the patient develops corneal ulceration, where you may have to go for amniotic membrane grafts. So an easier way treatment plan for dry eye, I would say, is first, treat the symptoms of the patient. It may involve tear substitutes, glasses, and moist sponges. Next, go for the aggravating factors. Find out when the patient is feeling his symptoms. If it's a young patient who is having a CVS, ask him to modify his working habits. Identify the drugs as mentioned, the first talk. Drug toxicity can also cause dry eyes. Next, treat the associated ocular factors. This may be seborrhea, staphylococcus, blepharitis, incomplete blinking, nocturnal lag ophthalmos. All this have to be thought about. Then treat the ocular surface. You have to look for entropion, ectropion, trichiasis, lid laxicity in old age, inflammation, limbal stem cell diseases. Then go for the systemic factors. As we are listening, autoimmune disorders are one of the mainstay in ocular surface disorders. So if necessary, involve the rheumatologist where the systemic factors have to get controlled. And finally, treat the patient. You'll have to be very supportive, empathetic to the patient, and constantly reassure the patient that it is a long-term management and it will take time to resolve. After all this main disease, I will also like to hint on some of the masquerades that happen in red eyes. The first one is tarsal foreign body. Many a times we miss tarsal foreign bodies. Patient comes with symptoms, we look into the lid, we look into the conjunctiva, cornea, we don't find anything. We just feel the patient is telling a simple complaint. But just a simple step of averting the eyelid of the patient may reveal a foreign body. Sometimes patient will present with a hint, the superior cornea will have an abrasion or some kind of a small ulceration that will give you a hint. But otherwise, even if the patient, if you can't find anything, always make it a habit to avert the eyelid and look for a tarsal foreign body. You can always remove it. I think many of you are aware of a video in YouTube where a patient, US patient presented with 20 contact lenses in a superior fornix. So even few of the patients who are not aware of the right use of contact lenses may have a retained contact lens in their fornices. Next one is acute angle closure glaucoma. I'm not elaborating, only just going to the treatment protocol where immediately, if the patient is in an acute attack stage, make them lie in a supine position, use aqueous suppressants, mannitol or acetazolamide to bring down the pressure. Once the cornea clears, go for a YAG PI. If YAG PI doesn't suffices and the patient goes for a chronic angle closure attack, the patient may require a surgery. Uveitis is something that we all know. I'm not elaborating again. It's important to rule out infective causes where steroids can be a problem. So always rule out infective causes, and mainstay of therapy is always corticosteroids, mydriatics, and other systemic drugs. Finally, episcleritis and scleritis. So the major thing that comes to mind is how to rule out an episcleritis and scleritis. Easiest way is to use a phenylephrine drop. Always in a 2.5% drop or a 10% drop, you can see the vessels will blanch once you use. That is, patient comes with episcleritis, put the phenylephrine drop, within 15 minutes you can see it resolving. In scleritis, that's not the way that happens. And always use a green filter while you're looking through the microscope, slit lamp. You can see that the deeper vessels highly well illuminated in the light. So it's very important to rule out differentiate episcleritis from scleritis. Thank you for giving me this opportunity.
Thank you, Doc. Dr. Bennet, I would like to ask you two questions on the MGD. So, when is this in-office or in-office therapy, that thermal pulsation, cost effective, or is the lid massage still a gold standard? Can you just
because the current machine that we have is a LipiFlow, so a single sitting costs the patient around 25,000. So what we tell the patient is that whenever, before advising the LipiFlow, we ask the patient to intensely repeat the lid massaging. That is very dedicated, like as you were telling, many a times the patient are not compliant to this. They just look it like a time pass, something that they do in the free time. So apart from that, ask the patient to do it vigorously. So if the patient is actually improving with the lid massage, you don't have to go for it. But saying that, many of us have actually underwent LipiFlow, and actually it makes a difference symptomatically.
okay, thank you.